So we're going to move into looking at some of the physiology, so the regulation of blood pressure. And so maintaining our blood pressure is going to be vital for the functioning of all of our body's organs. The blood pressure has to be great enough so that we have adequate perfusion throughout the body's tissues. So pathologically high blood pressure, though, can damage tissues as well. So there's a homeostatic balance that's necessary for regulating our blood pressure. There are both short-term and long-term regulation that are necessary and are maintained by the different organ systems. So short-term or acute regulation is by the nervous system and humoral controls. They work quickly and they can alter our peripheral resistance, for example, by increasing or decreasing sympathetic tone. Long-term regulation is by the renal system. The kidneys can counteract fluctuations in blood pressure by altering the blood volume. So, for example, they can increase reabsorption of water from the urine to increase blood volume or increase excretion to decrease our blood volume. And remember, an increase in blood volume increases blood pressure, or a decrease in blood volume decreases our blood pressure. So we're first going to look at those short-term mechanisms. We see the word neural, and we know we're going to be dealing with the brain. So the medulla oblongata, that area in the brainstem, has a cardiovascular center, and that maintains vasomotor tone, or moderate constriction of the arterioles, or it helps to change their blood vessel diameter. As we've just seen, changes in the diameter can affect resistance, and an increase or decrease in resistance is either going to increase or decrease the blood pressure. The medulla receives input from baroreceptors, chemoreceptors, and also the higher brain centers to control these vasomotor changes. Chemoreceptors pick up on changes in chemicals in the blood. So, for instance, a rise in carbon dioxide or a drop in pH to a more acidic environment or a decrease in oxygen alters the chemoreceptors and tells the brain that that tissue is highly metabolic and in need of oxygen. So when these are detected, these factors increase blood pressure to increase blood flow into a given area. The increased blood will bring oxygen and get rid of those wastes. Baroreceptor-initiated reflexes can detect the blood pressure changes in the great blood vessels. And when they do detect changes, then they are going to influence and send signals back to affect the heart rate. So if we take a look at how these baroreceptors work. So the baroreceptors are pressure sensors located in our carotid sinuses. So here we can see our two in the aortic arch and in the walls of the large arteries of the neck and thorax. So these baroreceptors can pick up both a decrease or an increase in blood pressure. A decrease in blood pressure inhibits the baroreceptors so that they activate the cardioexcitatory center and vasomotor center in the brain. And this is going to cause vasoconstriction, and that vasoconstriction increases resistance and blood pressure. And it also activates the sympathetic nervous system. So that gives our arterioles more sympathetic tone to increase blood pressure. And it also increases our heart rate. Remember, that will influence cardiac output. So an increase in heart rate increases cardiac output. The sympathetic nerves can also stimulate greater contractile force of our heart, and that also will increase our blood pressure. Now, what if the blood pressure is too high? So these receptors can pick up an increased blood pressure as well. Increased blood pressure stimulates the baroreceptors, and it is going to have an inhibiting effect. So what that will do, if you inhibit the vasomotor center, it will cause arterial dilation, and that will decrease resistance to decrease blood pressure. It also triggers the cardioinhibitory center, and that sends parasympathetic nervous stimulation to the heart to decrease heart rate. Remember, if you decrease your heart rate, you'll decrease cardiac output, and a decrease in cardiac output will decrease our blood pressure. Other short-term mechanisms are humoral controls. So remember what humor means in physiology. It means in the fluid or in the blood. So here we're dealing with hormones, and hormones can influence our blood pressure. So if you remember RAS, which stands for the renin, angiotensin, aldosterone system, many of these are coming from that system. Additionally, epinephrine and norepinephrine from the sympathetic nervous system can alter vascular tone by causing vasoconstriction. They can also increase our heart rate, our contractile force, and thus increase our blood pressure as well. So from RAS, you see angiotensin 2, antidiuretic hormone, aldosterone. They work by different mechanisms, but they will all be working to increase our blood pressure. If we take a look at how RAS works, ultimately the renin, angiotensin, aldosterone system works to create active angiotensin 2. Angiotensin 2 is going to be increased in the bloodstream when there is a decrease in blood pressure. And so it will be working to increase blood pressure by a couple of mechanisms. So first, it increases our thirst. If we drink, we'll bring water into the body, increase our blood volume and blood pressure. It increases antidiuretic hormone, which helps to reduce our water loss. It increases aldosterone, which aldosterone helps the body to reabsorb sodium. And if we bring in sodium, water will follow and we'll have water retention. And angiotensin 2 can work on the blood vessels themselves and cause vasoconstriction. So how do we end up with angiotensin 2? Remember, it's a process. So the kidneys actually secrete renin. That's the R in RAS. And renin is going to trigger angiotensinogen to become angiotensin 1. Angiotensin 1 travels to the lungs, and there's an enzyme here called ACE, for angiotensin converting enzyme, that converts angiotensin 1 to this active angiotensin 2. And then that angiotensin 2 will be free to work to do these mechanisms to increase our blood pressure. Why this is important in our discussions is because now that you have a mechanism to increase blood pressure, and people who have high blood pressure will see that this mechanism is overactive. And now we can target drugs to different components of it and block these mechanisms. So ultimately, we inhibit this angiotensin 2, and then we can inhibit water retention, salt retention. We can try to increase water loss and cause vasodilation to help somebody who has high blood pressure. We also have long-term mechanisms, and this will be taken care of by our kidneys. So long-term mechanisms of blood pressure control are over the span of days, weeks, and even out to years. The job falls to the kidneys, regulating our extracellular fluid volume and arterial blood pressure. These are generally around a given set point for any individual. When pressure increases or fluid volume increases, the kidneys will excrete the water and salt necessary to bring that arterial pressure back to around that given set point. In this model of the kidneys control, the blood pressure can increase by increasing the pressure set point higher for the elimination of excess fluid and salt, or alter the extracellular fluid at which the water and salt can be excreted. So the terms that we use in this discussion are diuresis, for increasing production of urine, and natriuresis, which is the excretion of sodium in the urine, which will cause water excretion as well. This chart then looks at the regulation of blood pressure. At the top, we can see that both cardiac output and resistance influence our blood pressure. Increase either, and blood pressure is going to increase. Decrease either, and our blood pressure decreases. As we move down this chart, we can see that whatever influences cardiac output or resistance will in turn influence our blood pressure. So if we examine resistance first, sympathetic activity triggered by the baroreceptors. And angiotensin 2, here's our angiotensin 2, can increase our resistance. Cardiac output is influenced by the stroke volume and heart rate. If the kidneys detect a drop in blood pressure, they can initiate the RAS mechanism by sending out angiotensin 2, aldosterone, and ADH. And as that blood volume increases, venous return is going to increase, and that will increase our stroke volume and increase our cardiac output. And that will all work then to increase our blood pressure. Blood pressure can be measured by a sphygmomanometer or a blood pressure cuff. We're generally concerned with two measurements: the systolic pressure, which is the maximal aortic pressure during left ventricle systole or contraction, and the diastolic pressure, which is the lowest aortic pressure during the left ventricle systole. It would be very difficult to measure the aorta's pressure. So our measurement is taken on the brachial artery in the upper arm. And so the pressure here is a little less than what would actually be at the aorta. In a healthy adult, we would expect the systolic pressure to be around 120 millimeters per mercury. And the diastolic pressure would be about 80 millimeters per mercury. And so we report these as a fraction with the systolic over the diastolic reading. Here in our picture, we can see the pressure changes. So the systolic pressure is at the peak during contraction. Our diastolic pressure is during relaxation.